Ma'am, we are on live, ma'am, and we are starting session, ma'am.
Okay.
So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is menopause and quality of life. I welcome all the participants. I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Surekha Chaudhary, ma'am. Madam has done her MBBS, MD, and DGO from AMU, and Madam is one of the senior most consultant obstetrician and gynecologist, and Madam is practicing currently at Shanti Nursing Home, Aligra, UP. So, with this short introduction, I welcome you, ma'am. Madam has a special interest of IVF and menopause treatment also. So, we welcome you, ma'am. I'm handing session to you for your presentation, ma'am. Welcome, ma'am.
Thank you, Priyanka.
Yes, ma'am, it's visible.
Yeah. Okay. So now, should I start now?
Yes, ma'am.
Yes, ma'am.
Okay. So today's topic is menopause and the quality of life during the menopause. It's a very important. It's a very important topic for all of us. Those who are in the menopausal or in the perimenopausal age group, or in the post-menopausal age group as well. So first of all, I will tell you how you define the menopause. The WHO defines the natural menopause as the permanent cessation of menstruation, which is confirmed only after 12 consecutive months of amenorrhea. In general, the natural menopause occurs between 45 and 55 years of age. In India, the range of mean age at menopause reported in different studies appears to be rather young. It is between 41.9 to 49.42 years. According to the Indian National Family Health Survey, like NFHS 3, which was carried out during 2005 and 2006, about 18% of currently married women in the age group of 30 to 49 years had reached the menopause. Now, concern has been expressed that the rate of premature menopause before the age of 40 years are very high, and it may be increasing in certain sections of the population. For example, NFHS 24 showed that 3.1% of the women in the age group of 30 to 34 years and 8% among 35 and 39 years, they were in the menopause. It further showed that 22% of the women in the age group of 35 to 39 years in Andhra Pradesh, they were in menopause, which was a significant observation, as the state has high prevalence of female sterilization at a very young age. However, these data included both the natural menopause and the hysterectomy. The proportion and absolute number of Indian women at the age 45 and above is likely to increase substantially in the next few decades. According to the 2011 census of India, there were about 96 million women aged 45 years and above, and this number is expected to increase to 401 million in 2026. As the postmenopausal years are associated with the health risks like hypertension, heart disease, osteoporosis, and the decline in the overall quality of life in this group will present profound future challenges. Now, there is an individualized plan for the menopause. Each woman needs an individualized plan for the menopause. It is most important to distinguish between a symptomatic and an asymptomatic menopause woman. Menopause, with like either they are symptomatic or they are asymptomatic. Like the symptoms of menopause are, they are divided into vasomotor symptoms, somatic symptoms, genital urinary syndrome of menopause, and neuropsychiatric symptoms. About the menstrual cycle, shortening of cycles that occurs in the late reproductive years is a clinical marker for the onset of menopause. Later, there is a lengthening of the menstrual interval, and some may have sudden amenorrhea. The vasomotor symptoms is the most bothersome symptom of menopause and the most common reason the women seeking for medical care. Vasomotor symptoms are associated with the sudden sensation of heat in the face, neck, chest, and it persists for several minutes or less. During a hot flush, the skin temperature rises due to the peripheral vasodilatation, particularly in the fingers and the toes. Along with peripheral vasodilatation and sweating, the heart rate increases by 7 to 15 beats per minute. This may take 30 minutes or longer for the skin temperature to return to the baseline. Now, the duration of vasomotor symptoms. The population-based prospective pan-ovarian aging study enrolled older reproductive women with regular menstrual cycles and followed them over 16 years. The mean age of participant was 42 years at the baseline and 51.5 years at the time of final menstrual period. A key finding was that median duration of hot flushes reported by the women to be moderate to severe was 10.2 years. Women whose symptoms began around the time of onset of perimenopausal transition, the median duration of symptom was 11.6 years. Now the somatic symptoms. The joint aches and pains are the commonly reported symptoms among the women at midlife. Women who are obese or depressed are more likely to experience joint pain. There also appears to be an association with the menopausal status with peri and postmenopausal women. They are experiencing more joint pain than with the premenopausal women. Now, body composition. Although the women typically gain weight during the midlife, it doesn't appear to be due to the menopausal status or the stage. In the early postmenopausal years, women typically gain abdominal fat mass and lose lean mass. Now, the skin changes. The collagen content of the skin and the bones is reduced by the estrogen deficiency. Decreased cutaneous collagen may lead to increased aging and wrinkling of the skin, frontal balding, and the hirsutism. Now, the genitourinary syndrome of menopause. The vulvovaginal atrophy, or the GSM, refers to the physical changes of the vulva, vagina, and the lower urinary tract, which results from the estrogen deficiency. Adversely affects the health, sexuality, and the quality of life of many menopausal women. The prevalence of urogenital symptoms in the postmenopause in the IMS study was 15%. It presents with
It's not audible, ma'am.
Madam left, I guess, Saiti.
Yes, sir. Yes,
Yeah.
sir.
Let's wait. Participants, there is some issue with the speaker. Please hold on.
Yeah.
Yes, ma'am. Now it's visible.
Very sorry. It was switch off due to light. I changed from moderately acidic range of pH from 3.5 to 5 to a neutral range of 6 to 8 in the vaginal pH. There is a shift in the vaginal maturation index. Now here the vaginal lubricants and vaginal moisturizers can be offered for the vaginal dryness and the dyspareunia. Local estrogen therapy is the first line of management and the only contraindication being active estrogen dependent tumors. Now the sexual problems in the menopausal women are the vaginal atrophy with the aging may lead to dyspareunia causing sexual dysfunction which is corrected by the local ET. Acquired sexual desire disorder in some women responds to testosterone therapy. Now the formulation of testosterone for use in women are not available in India and the testosterone preparation meant for the male should not be prescribed for women. Here the tebolone is a good option since it contains the androgenic activity and can be used to treat the libido problems. The central nervous system, the dementia. The core mental functions are the memory, communication and language, ability to focus and pay attention, reasoning and judgment, activities of daily living and visual perception. Impairment of any of two functions is suggestive of dementia. Many dementias are progressive. Early diagnosis will allow a person to get the maximum benefit from available treatment and provides an opportunity to plan for the future. For the best preservation of memory and cognition, women should be advised about the importance of good overall health, good cardiac and vascular health, exercise, maintenance of active mind, avoidance of excessive alcohol consumption, and measures to reduce the risk of diabetes and hypertension. At present, MHT is not indicated for neuroprotection. Not the depression. There is a significant increased risk of new onset depression in women during the menopausal transition compared with their premenopausal. Now the cognitive changes. Evidence supports the relation of estrogen to cognitive function. Women face problems with the memory loss and difficulty in concentration at the menopausal transition. A definite role of MHT for treating cognitive symptoms without VMS is lacking. Now the sleep. Pre and post-menopausal women, they sleep less, they have more frequent insomnia and are more likely to use prescription sleeping aids. Perceived decline in the sleep quality may be attributed to general aging effects, nocturnal urination, sleep-related disorders, for example, apnea or other illness like chronic pain or depression, then stress and negative mood, then ovarian hormonal changes. Hot flashes can trigger awakening in the first half of the night, but REM in the second half suppresses thermoregulation, thus the hot flashes. Decision on whether and how to treat with the behavior or the drug therapy or both will depend upon the severity of the sleep disturbances, context of sleep problem, distressing hot flashes or the life stress, and third is the severity of the daytime consequences. If the insomnia is identified, medical or psychiatric cause of insomnia should be ruled out, and if present, it should be treated accordingly. Lifestyle modification should be recommended as the first line treatment. If lifestyle modification didn't work, then hypnotics, benzodiazepines, melatonin agonists, they can be used in the short term, but there is no definite or convincing evidence to suggest its efficacy. This should only be prescribed by supervision of psychiatrists or the sleep experts. Mind-body therapists such as yoga have some evidence, but they need further rigorous study to prove its effectiveness. Now the mood disorders, feeling of upset, loss of control, irritability, fatigue, and the blue moods at the midlife may be caused by fluctuating hormone levels that perturb the neural system transiently. Women with a history of premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, or hot flashes are more vulnerable to depressive symptoms. The most predictive factor for depression at midlife and beyond is prior history of clinical depression. Now, the relaxation and stress reduction technique, antidepressant, and counseling or psychotherapy, they are the options to consider in symptom management. Urinary symptoms. Urinary complaints are very common in midlife women, but no link to menopause related estrogen loss has been identified. Over 50% of the women more than 50 with urinary incontinence also report symptoms of overactive bladder. Mild incontinence and early perimenopause tends to decline in the first 5 years after the menopause. Weight loss for overweight women is effective. Now, Kegel exercises can cure more than 50% of the cases of stress incontinence when they are performed regularly. Now, the osteoporosis. This is the serious health threat for aging postmenopausal women by increasing the risk of fracture. 13 to 18% of the white American women more than 50 years of age have osteoporosis of the hip. Lower estrogen levels account for about two-thirds of the bone loss during the 5-7 years around the menopause. Definitions based on BMD results: normal T score greater than or equal to -1. Low bone mass osteopenia, T score between -1 to -2.5. Now osteoporosis T score less than or equal to -2.5. Now the osteoporosis risk factors. The risk factor for osteoporotic fractures used in the FACS 10-year calculator are the advanced age, ages 50 to 90 years, parental history of fragility fracture, female sex, current tobacco smoking, weight, long-term use of glucocorticoids, height, rheumatoid arthritis, low femoral neck, bone mineral density, prior fragile fracture, alcohol intake of more than 3 units per day, other causes of secondary osteoporosis. Now, the osteoarthritis, epidemiological studies of a potential role for estrogen in osteoarthritis showed two very different findings. First, estrogen deprivation at the menopause seems to be associated with increase in the frequency of knee, hip, and finger osteoarthritis, and in the severity of hip osteoarthritis. Second, MHT for the menopause may decrease the incidence and progression of hip and knee osteoarthritis. So MHT may be indicated in these cases. Now the cardiovascular disease. Cardiovascular disease including CHD and stroke is second leading cause of death among the US women ages 45 and 64 years of age. Leading cause of death for women of more than 65 years of age. Now, congestive heart disease death rate in younger women ages 35 and 54 are increasing for the first time in 4 decades, secondary to obesity, diabetes, and hypertension. For the cardiovascular health, for better cardiovascular health, the total cholesterol should be less than 200 milligram per deciliter in untreated cases. HDLC at least 50 milligram per deciliter. LDLC is less than 100 milligram per deciliter. Blood pressure should be less than 120 by less than 80 millimeter of mercury. Fasting blood glucose should be less than 100 milligram per deciliter. BMI should be less than 25 kilogram per meter square. No smoking. Physical activity should be more than or equal to 150 minutes per week moderate walking or moderate activity, and more than 75 minutes per week, more than or equal to 75 minutes per week, vigorous or both. Healthy diet. Now, the last is the cancer. The menopause is not associated with the increased cancer risk, but because cancer rates increases with the age and cancer is the second leading cause of death in women, screen for the following cancers very regularly. Number 1 is the breast cancer. Mammogram should be done every 2 years. from 50 to 74 years of age. Now, colorectal cancer, colonoscopy should be done every 10 years, or fecal occult blood test, sigmoidoscopy, or the barium enema every 5 years, beginning from the age of 50 years. Now, endometrial cancer is the evaluation of any post-menopausal bleeding with a pelvic ultrasound and or endometrial biopsy. Ovarian cancer, no satisfactory screening test, but timely evaluation needed if presenting with the bloating, the pelvic pain, or urinary urgency. Cervical cancer, PET test should be done every 3 years or every 5 years if combined with HPV test. After a normal report, 3 years in a row for women aging 40 to 60 years. Now, screening is not necessary after age of 65 with 3 or more normal Pap tests in a row. No abnormal Pap test in the past 10 years or 2 or more negative HPV in the past 10 years. Now, the treatment for this. Hormonal replacement therapy. Hormone therapy like tablet, patches, or the cream is used to replace the estrogen that ovaries no longer make during and after the menopause. Hormone therapy may have either estrogen alone or estrogen plus progesterone. Generally, we use HRT for a short period of 3 to 5 years have been devised. Then the reduction of dosage should be done as soon as possible. Now, indications of HRT. Relief of the menopausal symptoms. Now, the prevention of osteoporosis to maintain the quality of life in the menopausal years. Then a special group of women to whom HRT should be prescribed. They are the premature ovarian failure, gonadal dysgenesis, surgical or radiation menopause. So the hormone for the 3 group of women, number 1, if you still have uterus, have not had hysterectomy done, then you need a treatment that combines the estrogen and progesterone. Now, estrogen alone if the hysterectomy has been done. Now, vaginal estrogen therapy is useful for the women who have local symptoms like vaginal dryness. Now, what are the risks of hormonal therapy? Number 1 is the endometrial cancer. Number 2 is the venous thromboembolic disease. There is an increased risk within 1 or 2 years after initiation of hormone therapy. Now, breast cancer, increased breast density with progesterone via proliferation of estrogen-dependent mammary tissue, making it more difficult to detect the breast cancer early with the mammogram. Now, 4th is the ovarian cancer. More than 10 years estrogen therapy, then ovarian cancer might develop. Then cerebrovascular accident, lipid metabolism, an increased incidence of gallbladder disease has been observed following ERT due to rise in the cholesterol in the bile. Now, there is a paper about the use of HRT and the risk of breast. This study has produced new generalizable estimates of the increased risk of breast cancer associated with the use of different hormone replacement preparations in the UK. The levels of risk vary between types of HRT with high risk for combined treatment and for longer duration of use. Commonly used estrogens are conjugated estrogen, 0.625 to 1.25 milligram per day. Progesterone used are medroxyprogesterone, they are 100 to 300 milligram per day. Considering the risk, hormone therapy should be used with the lowest effective dose and for a short period of time. The low dose of oral conjugated estrogen, 0.3 milligram daily, is effective and it has got minimal side effect. So it is advisable to use conjugated estrogen 0.3 milligram per day. Now, progesterone. Patient with a history of breast carcinoma or endometrial carcinoma, progesterone may be used. It may be effective in suppressing the hot flashes and it may prevent the osteoporosis. Now, medroxyprogesterone acetate 2.5 milligram to 5 milligram per day can be used. Tibolone. Tibolone is a steroid having weakly estrogenic, progesterogenic, and androgenic properties. It prevents osteoporosis, atrophic changes of vagina, and hot flashes. It increases the libido. A dose of 2.5 milligram per day is given. These are the prescription therapies, otherwise the estrogen and progesterone. Now the soya, phytoestrogen, black gauche. There is an increased interest in the soya isoflavone, which is a weaker estrogen supplements over the years. No conclusive evidence of improvement in the menopausal symptoms in 43 randomized trials. A meta-analysis of black gauche reported insufficient evidence to support the use of black gauche for menopausal symptoms. Thus, isoflavones, they are not suitable alternative to hormonal therapy. Even if you are giving isoflavone for 2 years, there are insignificant results. In this paper, they conclude that the daily administration of tablets containing 200 milligram of soya isoflavone for 2 years did not prevent bone loss or menopausal symptoms. The ideal menopause solution is should regulate the estrogen, non-reproductive organs, and reproductive organs. Should offer symptoms relief as good as hormonal therapy, without risk of cancer, VT, and a stroke, which may be associated with the hormone therapy. So the ideal menopause solution is that you give. One is to upregulate the non-reproductive organs and to downregulate the reproductive organs, breast and the endometrium. These are the, so now we'll come to the main thing, that is perimenopause, menopause and a post-menopausal group. The estrogen 100, if you are giving one tablet BID, regulate the estrogen affinity to estrogen receptors. Now it upregulates the estrogen affinity to ER in non-reproductive organs, causing vasoendothelium. It reduces in the vasoendothelium, so it reduces the hot flashes and the night sweats. And the CNS, and improves the mood swings and the insomnia. And in the bone, it improves the BMD. And it downregulates the breast and the endometrium, so there is no proliferation of MCF7 cells, so there is no risk of any cancer. Estrogen 100 non-estrogenic hormone regulator has no affinity to ER alpha and ER beta receptors. It inhibits the MCF7 cells. Evidence suggests there are 3 randomized placebo-controlled trials adhering to International Ethics Committee. One was conducted in USA and 2 in Korea. They were published in renowned journals. This suggests that the vaginal dryness, hot flashes, mood swings, and the bone pain. This study concluded on estrogen 100 group had significant reduction from 10 out of 12 Doberman index syndrome. They relieves the symptoms within 7 to 14 days. Now, to see the effectiveness and safety of estrogen 100 on perimenopausal women for 1 year, it was found that the osteocalcium was decreased from 6.02 nanogram per ml to 5.66 nanogram per ml after 1 year of treatment. And in the alkaline phosphatase, it decreases from 73.35 to 71 after 1 year of treatment. Now, this was a significant decrease in the both osteocalcium and the alkaline phosphatase. Now, bone mineral density was increased after 1 year from 0.746 to 0.763. This was a significant increase. Now, the biomedical evidences suggest that bone mineral density increases, serum growth hormone increases, serum osteocalcium decreases, serum triglyceride decreases, and the serum alkaline phosphatase also decreases. So, NIH study suggests it is 5 times more effective. Now, the evaluation of effectiveness and safety of estrogen 100 on perimenopausal women for 1 year suggests that in the treatment of estrogen 100 for 12 months, growth hormone was significantly increased. The effect of improvement of bone mineral metabolism was shown, and the increase in the femoral bone mineral density was observed. However, after estrogen G100 treatment, the increase of weight and commonly observed with HRT was not observed. Rather, the concentration was decreased. In result, while the side effect that is common with the HRT were not observed for 12 months long treatment, improvement of menopausal symptoms was confirmed. The treatment of menopausal women with estrogen 100 is observed to be effective and safe for the improvement of symptoms. So the therapeutic lifestyle management, 3-step management of menopause. Eat right, do the exercise, and take the medicine. Therapeutic lifestyle management, physical activity, that is the targeted exercise, nutrition, avoid alcohol and tobacco, stress reducing strategies, meditation, paced respiration. That is basically the thing in yoga. And massage and hobbies, nutrition, emotion stability, positive attitude, the family involvement, spiritual attitude, and the sleep. Now, living with the menopause with a balanced and nutritious diet. For the mind, your food, that is the main thing. Balanced diet for adult women. You have to take the diet in special measures. Like you take the carbohydrate about 275 grams, like cereal and millets, all 30 grams in 9 divided doses. 300 grams of all the vegetables, like 100 grams in 3 divided doses, and the fruits like 100 grams in one time. Like 300 grams of milk and milk products, pulses, and both vegetarian, non-vegetarian, 60 grams, 30 grams of, in case of non-veg, protein. Now fats and oils, 20 grams, and 20 grams of sugar. So this is the amount total which you should try to take. Recommendations are sugar 6 teaspoons per day, salts 1.5 teaspoons or 3 to 5 grams per day, oil 2 teaspoons per day, fruits are 100 grams per day, vegetables are 300 grams per day. Now drink 8 glasses of water every day and add powdered flaxseed, cinnamon, fenugreek, soft in salad and curds. Tea, coffee, and dairy products. Avoid more than 200 milligrams per day of caffeine. Limit the intake of tea and coffee to 3 cups a day. 1 cup of brewed coffee is equal to 120 milligrams of caffeine. 65 milligrams for 1 cup of instant coffee and tea. Consume a minimum of 500 to 600 ml of milk or curd, low fat, to build on calcium bank in wounds. Support it with lots of vitamin C rich fruits and vegetables to favor the calcium absorption. Now living with the menopause, like sleep hygiene, mind your sleep. Go to bed and get up at the same time each day. Sleep in a dark and quiet room at a comfortable temperature. Avoid large meal, exercise, caffeine, nicotine, and liquid 2 hours before sleep. Now maintain dim light bedroom environment with no gadgets around. Now the management of osteoporosis in the post-menopausal woman. Asymptomatic post-menopausal woman. If it is more than 5 years post-menopause, then again you do the bone mineral density by DEXA at the hip and the spine. They can be either normal or they can be either osteopenia, osteoporosis, or the severe osteoporosis. If it is less than 5 years post-menopause, then either one major risk factor or any other 2 risk factors, then you have to consider them also. Now, management of osteoporosis. In the normal cases, you can follow up 2 years later, reinforce the lifestyle changes. If there is an osteopenia and no risk factor, then you can do the follow-up. 2 years later, you can do the lifestyle changes. If there are one major risk factor along with the osteopenia and two other risk factors, no menopausal symptoms, then you can give hormone therapy, tebolone, bisphosphonates, relaxofene, strontium renylate. If there is one major risk factor with the menopausal symptoms, then you can give hormone therapy, tebolone, and bisphosphonates. And now, if there is osteoporosis and the menopausal symptoms, then you can give the hormone therapy, tebolone, and bisphosphate. No menopausal symptoms, then bisphosphonates, hormone therapy, relaxofene, strontium renylate. If there is severe osteoporosis, then teriparatide, bisphosphonate, and calcitonin. This is the MHT within 10 years of menopause. Now, management of osteoporosis. Post-menopausal women with the fragility fractures. If then immediate pain relief, you do the immediate pain relief. Surgical management is done. Calcium, vitamin D supplementation, and essential investigations are done. And rule put secondary causes. Follow-up is done. Then BMD, spine and the hip by DEXA. Repeat after 1 or 2 years. Then a bone markers for monitoring therapy. Now you have to go for multidisciplinary management. You go to the orthopedics doctor and super specialist for all this. Then there are lifestyle management, pharmacotherapy, teriparatide, bisphosphonates, calcitonin pain relief and vertebral fracture. Then physiotherapy is advised. Then rehabilitation, emotional support, social support, identify the factors for the recurrence, aim independence at home and work. That is the main thing. Now, living with the menopause. The nutrition, the recommended dietary allowance of calcium and vitamin D for adult Indian. The calcium is more than 800 milligram per day to 1200 milligram per day. Upper limit of normal is 2500 milligram per day. Now, vitamin D, second is vitamin D per day. That is 1500 to 2000 IU per day. Upper limit can be 10,000 IU per day. Now, the types of calcium supplement. The most common is the calcium carbonate and the calcium citrate. In the menopausal age group, we suggest the calcium citrate because the absorption is better in the absence of acid in the calcium citrate. This is the major difference between the two. Calcium carbonate needs acids to dissolve and for the absorption. Calcium citrate does not require stomach acid for absorption. Calcium carbonate, less stomach acid. As we age, need more acid. It may cause more poor absorption. So people over age 50, calcium citrate is better absorbed. Calcium carbonate to be taken with the meals should be taken anytime. It can be taken anytime. It is least expensive form of calcium. The calcium citrate may cost more. Now, calcium supplements. Thyroid medications, corticosteroids, tetracycline, and anticonvulsant, and calcium should be taken separately. Contraindicated in the patient with hypercalcemia, renal insufficiency, and with the caution in nephrolithiasis. Excess amounts more than 2500 milligram a day affects the kidneys and can reduce the absorption of other minerals like iron, zinc, and magnesium. Now, management of vitamin D deficiency. Cholecalciferol or the vitamin D tablets or the powder, 60,000 IU once in a week for 8 weeks, preferably with the milk. Or if you want injection, then one IM injection of 6 lakh IU is given to correct the deficiency, not to be repeated before 3 months, and may be given after confirmation of persisting low levels of vitamin D. Then maintenance therapy from natural sources or supplements is advised after correction of the deficiency. Now, the maintenance therapy, cholecalciferol tablet or the powder, 60,000 IU once in a month in summer, twice in a month in winter. or vitamin D supplements by oral spray or oral tablets 2000 IU per day, or injection of cholecalciferol 3 lakh IU IM twice in a year, or 6 lakhs IU IM once in a year. Cholecalciferol 1000 IU daily will raise the blood levels on an average by approximately 10 nanogram per ml. Now, the conclusion is that the women live 1/3 of their life in post-menopausal period. Perimenopausal and post-menopausal women may be affected by the symptoms and the condition associated with the hypoestrogenism, like vasomotor symptoms, vaginal dryness, and osteoporosis. In most of the women, hot flashes usually resolve without treatment. As the HRT have its severe drawbacks, non-hormonal management is the best choice of treatment in the menopausal issues. Complementary and alternative medicine is an efficacious treatment strategy. Eating the right diet along with the supplements, having adequate sleep, and exercise regularly can lead to a blissful post-menopausal life. Thank you.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. You have updated us through these menopausal symptoms and its complications, ma'am. Thank you, ma'am. Let me wait for 1 or 2 minutes for the participants to post their queries. If there is any queries, then I'll read it for you, ma'am. Ma'am, whether all post-menopausal women will be having these symptoms or only specific women will be having these symptoms, ma'am?
Only not all of them.
Okay.
Because in our society, they are not aware of this, that these symptoms are because of menopause. So the women who are coming to the OPD are very few. If the symptoms are very severe, only then they come to the doctor. Not all the females, so not all the females are having symptoms.
Okay, ma'am. Ma'am, this women who are undergoing this hysterectomy, whether they also can be treated with this non-hormonal treatment, ma'am, or whether hormonal treatment should be initiated at the beginning, ma'am?
Yeah, what? Please
In surgical menopausal woman, ma'am, like hysterectomy, who has undergone hysterectomy, in those case patients, whether this non-hormonal treatment will be giving better results, ma'am?
After reading all this, I suggest the non-hormonal therapy after the hysterectomy is advisable, because
Yes,
because in the young age, if the hysterectomy is done, the menopausal symptoms they appear. And if you advise non-hormonal therapy, like for 1 or 2 years to 5 years, the symptoms are resolved, and they can have a comfortable life. But after 45 years or 50 years, if they are having hysterectomy and having too much symptoms like cardiac symptoms or the hot flashes and this, and then they should be advised hormonal if it is required. But if she is comfortable with the non-hormonal therapy, then we advise only the non-hormonal therapy.
Yes, ma'am. Yes, ma'am. As you said, it can be used for a long time in a safer method, ma'am.
Yeah, it is a safe method, even if you are using it for 5 years.
Yes, ma'am. Yes. Thank you, ma'am. Participants, if you have any queries, you can just post in the chat box. If there is no questions, then we can end the webinar for today. Ma'am, there is no questions from the chat box, ma'am.
Okay.
So if you allow us, then we can end the webinar for today, ma'am. If there is any queries, then we will mail it to you, ma'am. You can address on those queries, ma'am.
Okay.
Yeah, ma'am. Thank you very much once again for being with us today, ma'am. It was a wonderful presentation again. And I would also thank our Ivaka team for making this webinar possible, ma'am. And I would also thank the audience for their active listening and participation, ma'am. Thank you, ma'am. Thank you, one and all.
Thank you.